So we're going to spend the next 45, 50 minutes or so talking about chromosomal abnormalities, which was probably the very earliest type of laboratory genetic testing done, and still has a role today. So there's some estimates that about 7% of human conceptuses will have a chromosomal imbalance, but for the more severe types, these are embryologically lethal, so we don't see them. They miscarry spontaneously. And of those products of conception where laboratories have looked for chromosomal abnormalities, the most common chromosomal abnormality seen is trisomy 16, which of course we've never seen in the newborn nursery, at least I haven't. And the second most common is 45XO, which we see in which condition? Turner's, very good. So the end result is about 0.5% of newborns will have a chromosomal disorder, but that doesn't necessarily mean that we can recognize that in the newborn period. So what might we see under the microscope? Well, practically anything you can think of. You folks are most familiar with the idea of trisomies, but occasionally in products of conception we can see triploides and tetraploides where there's 3 or 4 of every chromosome, clearly not compatible with life. And then we can see mosaicism sometimes, where not every cell has the same number of chromosomes. We can also see structural changes of individual chromosomes, so we may see deletions, and with the advent of microarrays, we can now see microdeletions, which you can't appreciate with a microscope. We can see duplications, we can see translocations, which may or may not be pathogenic, and we can even see portions of chromosomes turned upside down, which may be benign. When do we order a karyotype? Okay, here it is, 2017. When do we order a karyotype? Well, certainly in this particular age group, if you have a suspicious phenotype. So for example, if a doctor or a parent or a nurse says that baby looks like he might have Down syndrome, if the parent overhears that, whether it's correct or not, I think you're pretty much obligated to order the test because the parents will not sleep until they get a normal result. So the suspicious phenotype. Any infant with multiple congenital anomalies in a number of different organ systems, it's worth considering a karyotype unless you can explain that constellation of findings by a single gene disorder. And any newborn with ambiguous genitalia, because when a baby's born, what's the first question everyone asks? Is it a boy or a girl? And you look down and say, I'm not sure. Is that a medical emergency? Not so much. Is it a psychological and social and family emergency? It sure is. So you need to resolve that as best you can, bearing in mind that there are many ways to define sex. And the karyotype is not necessarily the one that trumps the others. So it's just another piece of information. In childhood, we may pick up children with chromosomal abnormalities because they have intellectual disability or mental retardation. Or maybe that suspicious phenotype needs to be grown into, if you will, and I'll give you a couple examples of that. And even into adolescence, we can pick up kids with Klinefelters and Turners who may have been missed previously. And as adults, there are reasons for getting karyotypes. About 1 in 1,000 adults is a carrier of a balanced translocation. And that individual and their partner may have a history of multiple miscarriages due to unbalanced translocations in fetuses. So that's an occasion where we have a perfectly appearing healthy person who may have a history of multiple miscarriages, and that's another reason to get a karyotype. This is a typical karyotype in this day and age. It's the same type of thing you would see if you did this 10 years ago, 20 years ago, 30 years ago, 40 years ago. So we have a pair of each of the numbered chromosomes. We number them from 1 to 22, from largest to smallest. And then down here, sequestered in the corner, we have the sex chromosomes, X here, and one small but exceptionally powerful Y chromosome. Some of you in the room may think that this is an abnormal karyotype due to the presence of the small but exceptionally powerful Y chromosome. The rest of us may disagree with you with all due respect, okay? So let's launch into some common examples here. These are 2 newborns I saw, I think, within a week of each other in the NICU. And the features aren't necessarily obvious when their eyes are closed and when they're nice and happy. but when somebody gets a little upset and starts to cry, the features may be a little more obvious. So these are 2 newborns with Down syndrome. So we can see, if we look hard, the upslanting palpebral fissures, a little more obvious here in this child who's upset, the flat facial profile, and the flat occiput, among other things. So let's look at this kid. This kid's 3 years old. I saw him as an outpatient because he had lack of meaningful speech at age 3. And the first question I asked the mother was, where have you been? 3 years is a little late, don't you think? I didn't get a satisfactory answer. So I looked at this child. He was otherwise perfectly healthy, well grown. But do you see any features that you're concerned about in this child? Well, I did. He's African American. You can see mom folded hands back here, a little too much flash on the face, but he's African American. And what do we see that we don't expect? What do we see that we do expect in terms of physical features? We do expect a flat nasal bridge because he's African American. We don't expect almond-shaped eyes, do we? And he is African American from both parents, so there's no interracial relationship here. He's got upslanting palpebral fissures as well, which of course we don't expect in an African American child. And he's got epicanthal folds. If you look very carefully, in the inner canthus, there's an extra skin fold. So, from the eyes up, he's a pretty good grab for Down syndrome. But he escaped detection for 3 years by the pediatrician or family practitioner, whoever was caring for him. But to the more trained eye, it was a little more obvious. But he was missed for 3 years, and I don't fault anyone for that because his features were relatively mild, but they were there nonetheless. Let's look at these 2 photos just to see if I can fool you here. The child on the left was 18 months old when I took that picture, and how many think she has Down syndrome? About 60% of you, okay? She has the open mouth, the prominent tongue, the flat facial features, the thin wispy hair, the almond-shaped eyes, the epicanthal folds, the whole bit, okay? The child on the right is a girl who's 4 years old. How many think that she has Down syndrome? About 20% of you, okay? What percentage you recognize the fact that this is the same child? Very good, okay. This is the same child 2.5 years apart. What happened in those 2.5 years? Did she have plastic surgery? No, she did not have plastic surgery. She had the benefit of occupational therapy and physical therapy and speech therapy and a loving family and some parents who stuck together and didn't end their relationship because they had a special needs child. So she hit the jackpot in terms of intervention and attention. And this is the payoff, okay? Happy child, happy parents, happy geneticist. This is what we like to see. So there's some parts of the country and some parts of the globe where these kids don't get all those benefits. But I think this country in particular is a little more tolerant and supportive of special needs kids, and she's just an early example of that. So that's why I show this slide. So we see Down's about 1 in 750 births, and you're quite familiar with the facial features. These kids can be hypotonic at birth, but not always. They tend to have slightly shorter fingers. About half of them will have congenital heart disease, so they all deserve an echo regardless of what age when they're diagnosed. In the newborn period, we may see some other problems such as duodenal obstruction. I've even seen Hirschsprung's disease in Down syndrome. Stature's a little bit short. There would increase risk for hypothyroidism and for partial hearing loss. And as we know, they all have intellectual delay. The primary defect we know is an extra chromosome 21. 95% of that, it's a separate chromosome 21. And in the other 5%, we either see mosaicism or an unbalanced translocation. What's new on this slide than from slide that I showed 20 years ago, or even 10 years ago? We have more sensitive screening methods prenatally to pick up Down syndrome. So prior to the advent of non-invasive prenatal testing, which is done from maternal blood, we had to rely on either amniocentesis or chorionic villus sampling to diagnose Down syndrome through invasive procedures. But NIPT, for the most part, has decreased the popularity of the invasive tests, but we still insist when we counsel expectant mothers that NIPT is a screening test. It's not perfect, but it's awfully close. And we really don't recommend interventions such as termination unless we have an invasive test to back it up. On the other hand, there are plenty of women who say, I'm not interested in an invasive procedure. There are sufficient ultrasound findings in the second trimester to support the diagnosis, and based on that, I want to terminate the pregnancy. And there are still many women and couples who, after counseling, say, we're going to continue this pregnancy. And that is certainly their right and privilege, and we as geneticists and counselors support them in their decision and say, great, okay, I'll see you at delivery. And that's how that works out. So this is a typical karyotype for a child with Down syndrome. We see 2 of each chromosome, and then if you're faced with a karyotype on your board exam, look for the arrow or the circle or something like that. That's probably where the problem is. So in this karyotype, the X chromosomes are put up here. This is an older nomenclature, and down here we see 3 separate chromosomes 21, trisomy 21. Occasionally we'll see an unbalanced translocation. For example, the extra 21 may be hooked onto chromosome 14, 14-21 translocation. But 95% of the time you have this situation here. Now, a lot of people make a big deal about the simian crease. And in this unretouched photograph of my former boss, who has an endowed chair at Vanderbilt, he has a simian crease in his palm. He does not need a karyotype. I've gotten the occasional phone call from a primary care doctor saying, I had this newborn baby with simian creases and the karyotype was normal. What do I do next? And I said, pay the insurance company $600 you just squandered because you examined the child from the wrist down. Again, Tiller's Law, when in doubt, examine the patient. Okay? So this is a common finding in about 10% of the population, just as clinodactyly, incurving of the little finger, is a common finding. Both are found more often in Down syndrome, but they don't have to be due to Down syndrome since they're common features. Here's a pair of twins I saw, let me guess, 2006. Which is the twin with the problem? The one with the NG tube and the one who hasn't filled out her cute little baby outfit. Yeah, pretty easy to figure out. So these were obviously fraternal twins born. The little boy here is thriving, very robust, and this little girl here has got the dwindles. You can see there's a little bit of abnormal posture to her fingers as well. She has trisomy 18, as does this little guy here who's trying desperately to make a muscle, but there's just not a whole lot there. So in him we see coarse facial features, we see low-set dysplastic ears, and we see rocker-bottom feet, for example. This child was about 3 months old when I took the picture. I think he passed away about 6 weeks after that. So Tri-18, not as common as trisomy 21, thank goodness. All of these kids show intrauterine growth retardation and failure to thrive. They tend to be hypertonic as infants. They have their share of congenital heart disease. They may have facial clefts, cleft lip and palate, dysplastic ears, small chin, overlapping digits, not always but often. They may have renal anomalies, and they have severe developmental delay. Most of these kids don't make it to their first birthday. Their life expectancy is usually measured in weeks or months. And it's very important to counsel the parents about that when the diagnosis is made. I'll often encounter these kids in an ICU setting, and a parade of subspecialists comes through, and each one assesses a different organ system. And it's more or less left up to me to look at the whole child. Because yes, we can fix that, no, we can't fix this. Yes, we can fix that, no, we can't fix this. What we can't fix is the brain. And the families need to know that. They need to know what they're in for, because that is going to frame what degree of intervention that they're comfortable with. So I like to get there first. So I like to be the first subspecialist to talk to that family, so that they can establish reasonable expectations. I think that's the most important thing we can do in kids with multiple birth defects for their families. This child, another NICU occupant who has a very low hairline, has very short palpebral fissures, a flat facial profile, dysplastic ears, and polydactyly. This child has trisomy 13, the least common of the so-called viable trisomies. Many, many features in common with trisomy 18. So how do you make the distinction? Before the lab test comes back, that is. Well, I look for a couple things here that are less common in trisomy 13. So I'll look for cutis aplasia, which is a full thickness scalp defect. I look for polydactyly, and I look for microphthalmia. In fact, we had a case in Los Angeles just last week where the eyes appeared very deep set, and if you palpated, you couldn't really feel a globe in there. And that child had microphthalmia as well, but had no congenital heart disease. So it's kind of a mix and match kind of thing. So I look for those three things. I look for polydactyly, I look for microphthalmia and cutis aplasia. Then I place my bet with the neonatologist, and I usually win. But these kids lose. The survival for kids with trisomy 13 is measured usually in days to weeks. And again, the parents need to know that as soon as possible so they can have reasonable expectations. Yet another case. I'm just full of cases today because I think this is a good way to learn things. It's how I learn things well. This is a newborn. Let me tell you a little story here, but first I want you in unison to tell me what physical finding you see that is blatantly obvious. It's a physical finding. You ready? 2 words. 1, 2, 3. Yes! Thank you very much. Web neck. Does anyone not see the web neck? Okay. Yes. Now I'll tell you the story. Tragic story. I tell this every year because I think there are a lot of teaching points in it. This is a little girl born to new parents, young new parents. They were very happy to have a little girl. Everybody was excited. And in the hospital, whoever was attending to that child, primary care doctor, pediatrician, family practitioner, I don't know who, said, "Congratulations, you got a little girl. I'll see you in about 3 weeks for your well baby checkup." And sent the baby home. A week goes by, 10 days go by, and the young parents were concerned because this baby wasn't feeding particularly well. And then the baby seemed to be breathing more rapidly than usual and looked a little on the pale side. So they didn't know what to do. So they took the baby to their local ER, and in the ER, the baby had a cardiopulmonary arrest. So the baby was resuscitated, was intubated, and was taken to the institution where I was training in Los Angeles. And at that time, diagnosis of what extracardiac lesion was made? Coarctation, okay? Why did this baby go into congestive heart failure? Because it was a juxtaductal coarct, okay? So good news was that the diagnosis was made, and the baby went to the operating room, and the coarctation got fixed, and the bad news was that she died on the table. I don't like consulting in the morgue. That's where I met this girl. So if we look at the physical findings, we see this very obvious web neck here. We see low-set ears. We see widely spaced nipples. We don't see an increased carrying angle, cubitus valgus, but what more do you need than this web neck to have the suspicion of Turner syndrome, probably on day of life 1. So what happened here? I'll never know what did happen here, but there are a couple possibilities. Either the web neck was not appreciated, not very observant, or whoever saw this web neck didn't know what to do with it. Didn't want to upset the parents, perhaps. Maybe it was a Friday afternoon and they had theater tickets and they were in a hurry and they just said, I'll see you in a couple weeks. I don't know. But my view of this is that this is a case of medical malpractice because of negligence. Now, how could this have been prevented? Because I think this was a preventable death. How could this have been prevented? Number one, tell the couple that you're uncertain about what you see and you are referring to a specialist. Let the geneticist be the bad guy if you can get him in within a period of time. Or say, it's Friday afternoon, I know you want to get home with your baby for the weekend, I'll see you Monday. Don't wait 2 or 3 weeks. And then you can have a more calm conversation with the family. Or ask a colleague to come in and talk to that family. If you're in a hurry or you're not comfortable or something, most of us don't work in a vacuum. We have a colleague we can ask for a favor. Any of those scenarios would have saved this child's life. So this is not a genetics point. This is more a practice point in knowing what your comfort level is and what do you do when you've reached that level. You ask for help. Because for all I know, had she survived, she could have grown up to look very similar to this 10-year-old girl who was diagnosed by her grandmother, who was surfing the net trying to figure out why her granddaughter was so short. And Granny nailed it. The pediatrician or primary practitioner had missed it because it's kind of subtle. Yes, she has short stature. Does she have a web neck? No. Does she have somewhat unusual looking ears? Yeah. Does she have a little bit of cubitus valgus? Yeah. So this is subtle. This is subtle. But hey, Granny picked it up. I walked into the room and I said, Granny, you're right here. You're a superstar. On the other hand, this is what we might see prenatally. So this is a Turner's fetus in the early second trimester, and we see gross anasarca, and we see this monstrously webbed neck which extends all the way around the head. This is why the 90% of Turner's fetuses spontaneously miscarry, because this is such a physiological stress on the fetus. So in the 10% that do survive, what do we see as the residua? Well, we see puffy hands and feet. So the dorsum of the feet, the back of the hands are puffy, and we see the webbed neck, the extra skin back here. So all this is resorbed in those that survive, and this is what we're left with. So I think you would appreciate the correlation of what you can see prenatally in extreme cases and what you see in the newborn period. So the Turner's cases that survive to term are about 1 in 2,500 births. And these are the features that you're familiar with. And congenital heart disease, including coarctation, are things that should always be looked for. So all kids in whom you suspect Turner's or who have Turner's need an echocardiogram. You can palpate or measure 4-quadrant blood pressures, 4-quadrant pulses. And all of these kids will have ovarian dysgenesis. So this is the most disappointing finding for parents often. These kids usually don't have much in the way of intellectual disability, but the parents are often, depending on the ethnic group, more so than others, may be crushed by the fact that their child will be sterile. And it's probably the most difficult part of the conversation at any age. But in this age of the internet, if you leave that off and say, oh, we'll get to that in some later appointment, the family's going to find out sooner or later. So you do have to at least mention that to some degree in the initial counseling session. In terms of laboratory findings, half these girls will have the classic 45X where one sex chromosome is missing. In another 25%, we may see one normal X and one structurally abnormal X as well. So there are 46 chromosomes, but one may be a ring where the two Q arms are wrapped around and there's a piece of the P arm missing, or an isochromosome X where there are two X's fused together and both P arms are missing. Bless you. And about 25% of the time we may see a mosaic situation. Now, it's not that difficult to diagnose Turner syndrome based on clinical findings. So why do we even bother with the karyotype? Well, two reasons. Number one, we have to convince the parents that's the diagnosis. And number two, we want to look for mosaicism, because maybe 10 or 15% of these girls will be mosaic and have some Y-bearing material. Now, we like to know that because if they have some Y-bearing material in a certain percentage of their cells, they are at risk for gonatoblastoma, because there may be internal gonads, and they may lead to gonadoblastomas. So we want to find these kids so that they will undergo prophylactic gonadectomy to eliminate the risk for gonatoblastoma. The other side of the coin, this was an 11-year-old kid that I saw a long time ago. And he was referred to rule out Marfan syndrome because at 11 years old he was taller than his father. And there was also some concern for his intellectual development because he was a Raiders fan. But in fact, he was doing okay in school. So we examined him from head to foot, and we're not impressed that he had features of Marfan syndrome other than tall stature. But about halfway between head and foot, we were under-impressed because he had small testicles. And that had been missed by the primary care practitioner because we tend not to look at the genitals beyond the newborn period, right? Just like we tend not to look at the skin beyond the newborn period, and we miss all kinds of things, which you'll see in our last lecture. So we felt that he did not have Marfan syndrome, but it turns out, as we suspected, that he had a new battery in his clicker, that he had Klinefelters. Klinefelters is even more common than Turner's. It's the most common sex chromosome anomaly. And these are the features that you're familiar with, so the tall, thin stature. I need to change the slide so it doesn't say mild mental retardation. There are some kids who have specific learning challenges, but I wouldn't put them into this category. A lot fail to go through puberty spontaneously. But I have to tell you that I have probably encountered more cases of adults with Klinefelter who were discovered when they came in with their spouse because as a couple they were infertile. And they masculinized just fine. They went through puberty spontaneously and had the sex appeal to get married and didn't find out that they were infertile until, as I said earlier, a reason for getting chromosomes would be a couple with infertility. And at that point, they are diagnosed with Klinefelter syndrome. So they are uniformly sterile and may not manifest these things which we traditionally associate with Klinefelter syndrome. So I'll see adult males with Klinefelter, and I think the other category is when women are getting amniocentesis or NIPT because of advanced maternal age or for some other reason, and we weren't looking for Klinefelters, but we found it. So it is found serendipitously, prenatally. And I will counsel those couples also to give them some idea of what they're in for should they elect to continue the pregnancy, and a lot do. So in this case, we have an extra X chromosome as well as the Y chromosome, and that is the karyotype in Klinefelters. And what do we do with these kids? Well, if they don't go through puberty spontaneously, then obviously they need testosterone replacement. In the adults who were diagnosed for the first time, there's really not much hope for fertility. Some people think that if you catch younger kids, you can biopsy the gonads and fish out some sperm and save them for a later date. I don't know how successful that is. But I know if you biopsy adults with Klinefelters, you will not find viable sperm in 99% of the cases. So that's a tragedy that the couples may only come across after they've had genetic testing as adults and tried to reproduce for several years. So those are kind of the two scenarios. Other than that, these individuals are pretty much healthy. And as I said, the intellectual disability I would downplay as a feature, okay? And this is a typical karyotype we see in Klinefelters. In this particular spread, the chromosomes are tall, but that's just coincidence here. But here we see 2 X's and 1 Y, so we have an extra sex chromosome. And that's what we see in Klinefelters. These 2 guys, unrelated, the boy on the left was 6 years old, the boy on the right was 3. And the boy on the left had intellectual disability. We would probably describe him these days as having autism. And he has a bit of a long face, and he has some slightly prominent ears. And he has a family history of a mentally retarded maternal uncle. So that raised our suspicion for Fragile X syndrome. The boy on the right was 3 years old and had no meaningful speech at age 3. Also had some generous ears, but had still had his baby face, so the long facial profile wasn't particularly appreciated. So in this boy, I had a family history, and I had a phenotype would fit Fragile X. In this boy, I didn't have so much of a phenotype here, at least facially. So what did I do? I invoked Tiller's rule. I examined the rest of the patient. And when I got to the genital area, I was impressed, because this boy in particular manifested macroorchidism. It's not a consistent finding in Fragile X, but when you do see it, it's another clue. So I ordered the appropriate testing for him, and sure enough, both these boys have Fragile X syndrome. For the most part, these boys can have close to normal motor development, but speech is severely delayed and may never develop in a lot of cases. So they are more often than not frankly autistic. They have these facial features which you can recognize. Much about prolapse is more prevalent, but really not medically important. And we can see macroorchidism pre-pubertally on occasion. Post-pubertally, it's more consistent. So if you don't see it pre-pubertally, don't discount the possible diagnosis. I include Fragile X in the cytogenetics lecture because traditionally, historically, we picked it up using a microscope and looking for the fragile site, which is a break point on the long arm of the X. Nowadays, it's a molecular diagnosis. The cytogenetic testing was finicky. You needed to culture the cells in a special medium, and it was awkward. Nowadays, we do it using PCR or Southern blot and can make the diagnosis of this trinucleotide expansion in about 7 to 10 days. I also want to point out that about 1/3 of female carriers will have a learning disability, probably because in embryogenesis, the female embryos will inactivate one of the 2 X chromosomes. That's a normal process, but it's a random process. And overall, you would think, well, it's a 50-50 chance that you're going to inactivate the X chromosome with a mutation on it. But if that is skewed, and it may be 60-40 or 70-30, then you can have a female who may have a learning disability. And here's an example of that. This is a young Hispanic boy who has classic Fragile X. He has a little bit of macrocephaly here. He has these large ears, the long face, and autism. And here is his sister, who is doing poorly in a couple classes in school. And she turned out to be a Fragile X carrier. So that explains her intellectual disability pretty well. So here's the cartoon version of the X chromosomes. The fragile site is down here, and it may appear pinched compared to this normal one. It's a bit difficult to see. As I said, we can pick up the Fragile X expansion by PCR, but for larger fragments, we need to use this technique called Southern blot, which has been around since the 1960s. And it's used to look for large alterations in gene or chromosome structure. So here we have pedigree with a couple who have an affected son, and this is the maternal grandfather. We know that since males have just one X chromosome, they should just have one spot on a Southern blot. And as you recall, a Southern blot is electrophoresis, so the smaller DNA fragments migrate more quickly, and the larger ones migrate more slowly. So the father here, who's unaffected, has a fragment containing that gene down here. The grandfather has a fragment up here, which is in the pre-mutation area. And the mother, having two X's, has one normal X and one that has her father's pre-mutation. What happened in her son? That pre-mutation expanded grossly so that way up here is that fragment. And this probably would not have been able to be seen with PCR, but is seen readily on a Southern blot. So there is still utility for using Southern blots in molecular medicine these days, even though it's very cumbersome. So that's what you can see in Fragile X. Diagnosis, Prader-Willi. Okay. This kid was 16 years old when I first saw him. I'm not sure he had ever been seen by genetics. He's standing here next to his father, and bless you. And he was mentally retarded. He was obviously morbidly obese. He's a bit microcephalic here, and he had relatively small hands and feet for his size. And this is his growth curve. So when he was maybe 3 or 4 years old, his weight was right at the bottom of the growth curve, about 5th percentile. But it only took a couple years for him to blast his way right through the normal range. And by age 16, it looks like this spot belongs more on the height curve than it does on the weight curve. And you can also see that he is short because the parental heights are here and his height is down here somewhere. So short stature and morbid obesity. So we see Prader-Willi about 1 in 20,000 children. They tend to be hypotonic at birth, and they may actually have feeding problems in birth because of the hypotonia. So some of these kids may go home with a nasogastric tube or a gastrostomy tube, and then as time goes by, that hypotonia resolves, they become ambulatory, and they ambulate to the kitchen quite frequently, to the point where parents may have to padlock the refrigerator and put food out of reach because these kids are very determined and have an appetite that they can't control. And that's why they develop obesity. And it's very, very difficult to control these kids and their appetite. It's a 24/7 job. They have facial features, which I'll show you again in a minute. And from a cytogenetic standpoint, they may have a deletion on chromosome 15, the long arm of 15, that you can see either on a routine karyotype or more successfully by fluorescence in situ hybridization. I'll show you that in a minute. 25% of them may have uniparental disomy, where they have 2 copies of the maternal chromosome 15 and no copy of their father's chromosome 15. And then others may have abnormal DNA methylation patterns on 15q. So I'll explain all that in just a minute. So this would be FISH for Prader-Willi. If you order a FISH test, you have to specify what you're looking for because there's just one particular DNA probe. So if you're thinking about Prader-Willi, you ask for that FISH test. If you're thinking about Williams syndrome, you ask for that FISH test. And that's the only thing that will be picked up. So the gene of interest is called SNRPN. And this is the probe for SNRPN. So this is the normal chromosome 15. And you don't see this thin sliver over here on the other chromosome 15. So there's a deletion. And that's seen here. And even on this blown up example down here, it's very hard to see that consistently when it's missing. So the FISH is much more sensitive. But even more sensitive than that is a DNA methylation test. So keep that in mind. The first test of choice for Prader-Willi is DNA methylation for chromosome 15. Okay? So here's a series of boys with Prader-Willi, 5-year-old, 6-year-old, 10-year-old, and an adult. And they all have very similar facial features. So they have almond-shaped eyes, even though none are of Asian extraction. They have epicanthal folds, and it looks like esotropia is not that uncommon either. And they all have some level of intellectual developmental delay. This boy here was an exception. He was actually a pretty good reader in grade school, but the other boys did very poorly. And this gentleman here was in his mid-30s the last time I saw him, and he was morbidly obese. He had diabetes, and he passed away a couple years later than that. He also had obstructive sleep apnea, as you might expect. That's interesting. I'll probably need help in making this go away. Wow, this is really psychedelic here. Could you help me out there in the back of the room? Yes. Thank you. Okay. These are two kids who also have defects on chromosome 15q11, but they have a very different phenotype from what we saw in Prader-Willi syndrome. This boy at 9 years old is microcephalic, mentally retarded, and ataxic. So you see here at age 9, he's strapped into his wheelchair because he cannot any longer ambulate on his own. This 3-year-old girl over here was also somewhat microcephalic and had epilepsy and didn't have much in the way of ataxia when I first saw her. But she had problems with coordination and use of her hands. So she was referred to me by the neurologist to consider Angelman syndrome. I wasn't convinced. I sent her back to the neurologist and said, no, I think she might have Rett syndrome. This is before we had the gene for Rett. And then he ordered the Angelman testing, and sure enough, it came back abnormal. So I felt a little sheepish in that regard. Both these kids had inappropriate laughter and inappropriate good disposition, and that was, of course, another clue. So this is Angelman, and it's a very different phenotype. We do see microcephaly again, but then we see this broad mouth and the prominent jaw and ataxia and inappropriate laughter, and in almost all cases, frank autism, no meaningful speech, and epilepsy is not uncommon. Under the microscope, we may see findings exactly the same as we would see with Prader-Willi syndrome. But what is the difference here? Well, the difference is in Prader-Willi syndrome, the defect is on the paternal chromosome. And in Angelman syndrome, the defect is on the maternal copy of chromosome 15. So here, 7% of kids with Angelman syndrome will have paternal uniparental disomy, which means they had 2 copies of the father's chromosome 15 and no copy of the mother's chromosome 15. The parents' chromosomes are perfectly normal, but how can UPD happen in the first place? The theory is that that fertilized egg was trisomic for chromosome 15, which we know is lethal. But somehow that fertilized egg decided to randomly spit out 1 extra chromosome 15. And if it spit out the only copy of the paternal chromosome 15, then you have Prader-Willi syndrome. Paternal P, paternal Prader-Willi. Okay? If that fertilized egg happened to spit out the only copy of the maternal chromosome 15, you have Angelman syndrome. Mothers are angels, so that's how you remember that. Question in the back. No question. Yes?
Are these sex-linked?
These are not sex-linked. I have all pictures of males with Prader-Willi, but I have seen plenty of females with Prader-Willi as well. Okay? Maybe it's a little bit easier to appreciate a micropenis than hypogonadism in a female. I don't know. So again, the first test of choice here is not a karyotype, is not a FISH test, but DNA methylation. because the methylation can distinguish between maternal and paternal copies, and you can see which one is missing. So DNA methylation, again, first test of choice for Angelman, first test of choice for Prader-Willi. Now, what's this all about? You've got identical genetic information on chromosome 15, whether it's maternal or paternal, but is that information used from both copies? And the answer is no. There is a normal process called imprinting. This is a normal physiologic process, which we really didn't even know existed until someone figured out the difference between Prader-Willi and Angelman syndrome. So imprinting means that identical genes may somehow be marked during development of the germ cells in the parents, and that influences gene expression. So there are certain parts of each of our normal karyotypes, certain parts of some chromosomes that are switched off on either the maternal copy or the paternal copy. There aren't too many of those regions, but chromosome 11 is one of them, chromosome 15 is one of them. And only when you end up with an imbalance in the chromosomes do you see that imprinting manifest itself. So we see it in Prader-Willi, we see it in Angelman syndrome, we see it in some forms of familial paragangliomas, and we see it in Albright's hereditary osteodystrophy. So imprinting is a normal process, but when you have an imbalance in one of those imprinted chromosomes, you can see a genetic syndrome. This is a girl I saw over time. And I mentioned earlier that some people sort of have to grow into the features of a genetic syndrome. This is a prime example. I first saw this girl in infancy because she was a little bit dysmorphic. But I really couldn't put my finger on anything that pointed to a particular syndrome. So at the time, I ordered a routine karyotype, and it came back normal. And I asked the parents to come back in 6 months or so. Well, Dad was in the military, and he got deployed to Europe, and 6 months turned into 4 years. So she comes back when he's redeployed back to the States, and here's this little girl at about 4.5 years of age. She's cuter, for sure, but she's also a little distinctive looking. So she has an unusual smile. She has sort of a pixie or elfin-like face. And she had a little bit of a hoarse voice. And while she was waiting for me to see her, she was sort of making the rounds of the waiting room, walking up to total strangers and saying hi and shaking their hands and having a little conversation with them, as if she was running for office. Some people call that the cocktail personality. I might call it the candidate personality. But that was the most distinctive feature of her behavior, which we could not see in the newborn period. So she has Williams syndrome, as do all of these kids here. She's down here in the corner here, and these are kids of various ages who all have Williams syndrome, and you can see some of the features that are in common here. So the look of the nose here, most of them have prominent thick lips, and only in the older individuals, this guy's in middle school, and this is obviously an adult, do the features sort of fade away a little bit. But these kids will have some degree of intellectual disability. They may have peripheral pulmonic stenosis, and they may have hypercalcemia in the newborn period. But for the most part, they're pretty healthy. But they do have varying degrees of intellectual disability. And this is an example of fish for Williams. Again, this is chromosome 7, this is the particular probe, this is the normal chromosome 7, and this is the abnormal one where that region is missing. So these are some examples of contiguous gene syndromes where more than one gene is missing from a particular chromosome. So that's part of Prader-Willi and Angelman, Beckwith-Wiedemann, which you'll see in a minute, Williams to George, and I'll finish up with examples of the last two. So what's missing on this newborn chest x-ray? Soft tissue. There's no thymus. Was it called out by the radiologist? No. Okay. Well, it's important because this is what that child looked like 3 months later. She hadn't even left the hospital yet. She was born with tetralogy of Fallot, thymic hypoplasia, hypocalcemia, and lymphopenia. So she had the classic triad of DiGeorge syndrome. I prefer this acronym because I think it's exceptionally clever. I can't take credit for it. But Catch-22 includes DiGeorge syndrome with the classic triad. It also includes Imprinting syndrome, velocardiofacial syndrome, where you don't have the absent thymus and you don't have the lymphopenia, but you can have cleft palate and congenital heart disease. So these are the features. This is where the acronym comes in handy. So we see cardiac defects, abnormal facial features, thymic hypoplasia, cleft palate in Imprinting's but not in DiGeorge, and hypocalcemia in DiGeorge. So the defect here is on chromosome 22q. It's a well-established condition, and you can pick it up by FISH, and you can also pick it up by microarray. So here's some other individuals with DiGeorge or velocardiofacial. This fellow here has velocardiofacial, so he had a cardiac septal defect. He's got a little bit of hearing loss, and he's got this very long kind of hose-like nose. And both these individuals had something unusual about their ears, as well as this kid here. So that's what we see in Catch-22. This little guy here I first saw as a newborn, and this picture taken in infancy, and then I followed him over time. He's Korean, so hence the epicanthal folds and the almond-shaped eyes, but the hypertelorism is striking, and so is the microcephaly. And so was his cry as an infant, because it was very weak and high-pitched. And he was very hypotonic, and it took him years to walk, so he actually had a kiddie walker. I think today they're called gait trainers. It's a walker. And now he's finally able to ambulate. He has a little piece of chromosome 5p missing. He has Cri du Chat Syndrome. So that constellation of hypotonia, microcephaly, hypertelorism, and high-pitched weak cry, which some people sounds like a kitten, is Cri du Chat, cry of the cat. I want to finish up with this. This is a newborn I saw a couple years ago with a very obvious omphalocele. And I hope you can distinguish omphalocele from gastroschisis. Omphalocele involves the umbilicus, whereas gastroschisis does not. And he had a couple other features that you need to see. He had such a large tongue that he required a tracheostomy to maintain a patent airway. And he also had some pits and creases on his earlobes. And he had transient hypoglycemia as a newborn, and he was a large baby. So he's got Beckwith-Wiedemann. And these are the features that we see in that. So large for gestational age, as you might see in an infant of a diabetic mother. The large tongue, the ear pits and creases, organomegaly, omphalocele, and occasionally hemihypertrophy. As I said, these kids are at increased risk for hypoglycemia. They're also at increased risk for Wilms tumor and hepatoblastoma. So these kids require serial ultrasound evaluations every 3 months for the first 6 to 8 years of life. The primary defect is on chromosome 11, and probably the best test here, again, is DNA methylation. Here's another kid with Beckwith-Wiedemann, a little girl of South Asian ancestry. We see in infancy she had limb length asymmetry with rather impressive increased circumference of the right thigh. And she got a little older and she got a lot cuter, but we can also see that she had hemihypertrophy involving her tongue, which didn't interfere with her speech or her chewing, but was another reminder that she had hemihypertrophy. But she otherwise did pretty well. Last 2 slides I want to show. I talked about karyotypes, I talked about FISH. I want to mention microarrays or comparative genomic hybridization. This is often the first-line test now instead of getting a karyotype. So when might you want to use this? Well, this is sort of like a super-sensitive karyotype, but it uses molecular probes instead of a light microscope. So you can see very, very small deletions or duplications. And I would consider it the first-line test for isolated autism, when kids are not dysmorphic, but they have autism. So don't even bother with a karyotype. So in males with autism, you might consider Fragile X and a microarray. In girls with autism, you might just consider the array by itself, unless there's a family history suggestive of X-linked mental retardation. And occasionally you can find other things when the karyotype is perhaps normal. One last case to follow up here. This was a girl I saw at age 4 who was born with a cleft lip. Prenatally, she supposedly had 47 XXX, which does not include cleft lip as one of its features. And she had a little bit of short stature and developmental delay. And I couldn't figure out what in the world was wrong with her. So we did a microarray, and we found that she had a little piece of chromosome 7 missing, and that defined her phenotype. Because once I looked up what was there and what was missing, I ran across a condition I had never seen or heard of before, hand-foot genital syndrome. And sure enough, on pelvic ultrasound, she did not have any internal female organs. And her x-rays showed very small distal digits. So here's an example of a very sensitive molecular test which surveys the entire genome at a certain level of resolution and allows you to make more diagnoses of some of these so-called microdeletion syndromes. Alrighty. We'll skip this in the interest of time. You can, if you're interested about direct-to-consumer testing, which is the bane of our existence, you can catch me at the break, okay? See you in a bit.